I'm Josh Edgerton, and I'm a general surgeon with Rutherford Surgical Associates. The vascular disease that I treat is actually arterial disease. And so what can happen is patients can get little blockages in their arteries that feed their leg. And that leads to pain with walking, and that can be in the calf muscle. And then if it gets more advanced, it can be pain in the foot, and that can actually happen even at rest. And as the disease process progresses, then the patients can get little ulcers on their feet that will fail to heal. And we call those arterial insufficiency ulcers. And what'll happen is their foot will just get a chronic wound, and that can be a sign of arterial disease. And what we can do is go in there and clean out those blockages, restore blood flow down to the foot, and wounds will heal, pain will resolve, and patients can get mobility back and get their lives back. Typically, it fixes their problem right away, and that can be very long lasting. Every once in a while, new blockages will develop in other spots, and we'll have to go back in and clean it out again, but it's a procedure that can be repeated. And if a patient gets another blockage, we can do it again, so we don't burn any bridges by doing it once to them. So what we've been doing here is endovascular surgery, and it's a minimally invasive vascular surgery involving a puncture site into a vessel in the leg, and then through that puncture site we can guide wires and catheters, and using special types of catheters we can open up vessels by either drilling out the plaque and drilling out the calcium, or ballooning it open and then leaving a stent. So there's different options that we can do. And it's been working really well. We've restored a lot of blood flow to feet recently. We'll first start with a physical exam and evaluate their symptoms and how their pulses are and how their feet look. And if it looks arterial, then we can verify that with an ultrasound, which is non-invasive. And if that verifies that there's arterial insufficiency, then we can actually see the lesion or where the blockage is located using a CT scan. And then based on the characteristics of the blockage, we can know if it's a patient we can treat. A variety of both. If they are coming out, or if they're coming to us from the outpatient setting, then usually it's an outpatient surgery for them. If it's a really severe disease process where they're coming in from the ER and they're admitted overnight and then they have to have the procedure done, they usually then stay overnight, but it can be done either way. The colonoscopy is a great procedure. We can see all kinds of stuff inside someone's colon. You can see inflammation, we can see polyps, we can see masses, and take pictures of all those things, and anything that looks concerning we can biopsy and get a path report on. And then certainly polyps, we can snare those and remove them completely, and then those patients are be prevented from colon cancer in the future if we can get those polyps out of them. Diverticulitis is inflammation of diverticuli, and diverticuli are little pockets that form in the colon, usually in the sigmoid region of the colon. And those little pockets can be there, and they can be asymptomatic, which is diverticulosis, but when they get inflamed, that's diverticulitis. And surgery for diverticulitis would be indicated if the patient starts to either have multiple attacks or complicated cases where there's either bleeding or perforation or strictures. It is common as patients age, but certainly it can be worse with patients who have chronic constipation. So straining on the stool and having chronic constipation leads to these pockets forming. So trying to avoid that can be very healthy for the colon. If it's something that we do electively on an outpatient basis, we can do it laparoscopically. And with the new protocols that we have, patients are staying 2-3 nights now, and can get back on their feet and back having bowel function just after a relatively short stay. If the patient comes in needing emergency surgery, it's sort of a totally different ball game. They're going to stay a little bit longer in the hospital, but we can certainly get them through and get them home. I've noticed that some people are kind of reluctant because they've maybe heard about it could perforate your colon, and what I say to that is I guess it can, but it's extremely rare, and I've never seen it happen. So I think the amount of good that we can do with a colonoscopy greatly outweighs the risk. It's, in my mind, a really low-risk procedure and has a lot of benefit for patients. That's a great question. And that's age 50. Everyone should start getting them at 50 if they're at just average risk. If that colonoscopy is normal, then they can stretch that out for another 10 years. If there's polyps, depending on what kind and how many, then that would increase the frequency of needing surveillance. So if they're having a lot of tubular adenomas pop up, they may need to have another colonoscopy in 2 or 3 years. Patients with a strong family history, so if they have a parent or a brother or sister who's had colon cancer, then those patients need to have their screening done at the age 10 years younger than when their family member was diagnosed with the cancer.